This lecture is about non-cardiac chest pain. So non-cardiac chest pain is recurrent substernal chest pressure or other chest discomfort believed to be unrelated to the heart after a reasonable cardiac evaluation. So it's really important, as we all know as nurses, to distinguish cardiac from non-cardiac chest pain. The epidemiology is interesting and reassuring somewhat because most episodes of chest pain in primary care are non-cardiac in origin. About 67% of chest pain was related to musculoskeletal, GI, psychiatric, or pulmonary disorders. Only 16% was found to be cardiac in nature, and another 16% was idiopathic. So we just couldn't define what was the etiology. The diagnosis of chest pain is most often obtained with a detailed history, a physical exam, ECG, or a chest radiograph if that's indicated. And ruling out cardiac causes of chest pain is the essential first step. The pathogenesis is the sympathetic chain, vagus, and the phrenic nerves are all the structures in the chest, and they have overlapping innervation. So pain from different organs, including the abdomen, may have similar referral patterns responsible for carrying these pain impulses into the thoracic cage. So really, you have to make consideration that it could be multifactorial. What is the etiology of the chest pain because of this innervation of the chest and the abdomen? So clinically, the patient will present with a history of chest pain, and that particular specific individualized history is crucial for the diagnosis and management of chest pain. You have got to question carefully that patient related to the character, the quality, the location, the intensity, duration, aggravation, and alleviation of the chest pain they're describing. And that's exactly what you're asking them to do, is specifically describe. Within that description, also their personal medical history and their family history. Any recent strenuous physical activity, do they have heartburn, dysphagia, reflux, blood in the stool, any overt stress in their life, do they use drugs, and what medications, including their over-the-counter medications. Physical exam would include general appearance and vital signs, and it always begins with the exclusion of cardiac disease. In non-cardiac chest pain, really you should expect the vital signs to be normal. You're going to include in your exam a thorough neck exam looking for adenopathy, vein distension, or trachea deviation, and then move to the chest for any sign of rash, trauma, palpate the chest and assess range of motion of that upper body, percuss the chest for dullness, auscultate the lungs for abnormal breath sounds, and heart for murmurs or extra heart sounds or friction rubs. So you're really doing a comprehensive exam. You want to include also the examination of the abdomen for tenderness or orgomegaly, and then move yourself all the way down to the lower extremities and looking for edema and just hair distribution, vascular integrity of their lower extremities. So again, this is a comprehensive exam with the idea of excluding cardiac disease. I do want you to put in your toolkit that many patients with non-cardiac chest pain will have a completely normal exam, and that's one clue. Diagnostically, you're going to get a 12-lead EKG or ECG. Normal ECG really reduces the likelihood of any acute coronary syndrome about 70 to 90% of the time, but do remember it does not completely rule it out. So you've got some level of confidence, but knowing a normal ECG is good, but I have to also put the other clinical pieces together. And you've got to interpret that ECG in the context of the patient history and risk factors of heart disease. So a normal ECG in persons less than 40 may be enough to rule out cardiac disease. People over 40, not enough. You want to get a pulse oximetry in primary care on a patient with non-cardiac chest disease. Older patients and those with risk factors may need added cardiac enzymes, stress testing, which, remember, is less reliable in women, and coronary angiography. Chest x-ray may also be useful in detecting cardiac and pulmonary abnormalities. And the author of our textbook says that an empirical course of a PPI is a reasonable first line to diagnose GERD as a source of chest pain. So they go through our reading other causes causes of non-cardiac chest pain and what would be reasonable to rule out or rule in what the correct diagnosis is. So management and treatment of chest pain really depends on the cause of the disease process. Exclusion of coronary artery disease and life-threatening causes of non-cardiac chest pain is really the first step. But if the cause is ruled to be GERD or musculoskeletal, pulmonary, or psychiatric, it's really guided by the appropriate interventions for these conditions. And I want to refer you back to page 449. So when do we refer? The lack of response for a non-cardiac chest pain like GERD, you refer to a gastroenterologist. Abnormalities on the chest x-ray, such as a MASH, those referrals to our pulmonologist or an oncologist. And patients with pulmonary embolism really require a further workup, a D-dimer, a chest, usually it's a spiral chest CT that we order. But, pulmonary embolism really heightens the emergency and immediacy of referral to the hospital. And they do a really good job in box 104.2 on page 450 reviewing referrals for non-cardiac chest pain. Clinical signs warning immediate transfer to a higher level care, of course, is referral, like the PE, pneumothorax, a pneumonia with respiratory distress. All these things we already know and as nurses. So patient-family education for non-cardiac chest pain can cause, we've got to let our patients and family know that it can cause significant morbidity depending on the cause. They need to really understand clearly what their diagnosis is when it's non-cardiac chest pain and the possible complications. So what you're doing is not only educating about the diagnosis, but you're educating that it's not a cardiac origin. And then you have to further educate to recognize cardiac, pulmonary, or musculoskeletal chest pain and what actions those patients need to take. Counseling on smoking cessation should be included if they are a smoker, and medication instructions specific for the origin of their pain. Thank you.